When you're a surgeon, the biggest thing you can do is see. So when we set a case up, back up to 1950, exposure is everything. If you can't see what you need to work on, you're just not going to be able to do what your goal is. And so exposure is key. How can we get exposure and yet shrink things down? And that's always where we've graduated from open procedures to open procedures with small incisions, better instrumentation that allows through experience and engineering that give us the exposure to see what we got to work on through a smaller incision, to working with thoracoscopes where we go in with a camera and through port sites where we're not having to spread ribs and cut muscle of any sort, just go in with a poke. And small millimeter pokes. The big one, old thoracoscopes were big 12 millimeters all around, and now they're down to 8 and 5 millimeter scopes. So small poke holes, giving you wonderful camera. This is all technology advanced. From thoracoscope, where you're holding the scope and you're working the instruments, to now robotic. Robotic is the surgeon sets the case up, puts the ports in the area of based on what particular procedure they plan to do. The ports go in a different area of the body, whether you're a urologist working down in the prostate, or you're a general surgeon working up in gallbladder or colon, or in our case doing lung surgery, esophageal surgery, or even heart surgery. These robotics, it's a 4-level or 4 different ports. They are all controlled by the surgeon, who's not at the side of the table. He's in the corner working on a console. Gives you 3D imagery. Everything is magnified 10 times. You see the tiniest vessels going into a lymph node, and you can bipolar cauterize them. So the blood loss is nil, and you get better visualization to see your lymph nodes and see around for your dissection. The robot is truly an amazing instrumentation. So we're now taking lobes out for lung cancer through 4 little port sites. The patients are going home in 2 to 3 days as opposed to 5 to 10 days. They don't have an incision that they're going to have soreness through at home. We still need that incision for different other, not everyone qualifies, but it's a lot of them do. Thyroid or thymus in front of the heart. And we'll graduate right now from that is thoracic surgery, working with the lungs and esophagus, thymus and so forth, to heart surgery. And that's where we'll be going inside the heart with the same robot, repairing mitral valves with it all through a poke hole, which is very exciting. If someone's had previous surgery on their lung, or for whatever various reason it has scar that you're not able to drop the lung down and so forth, these are contraindications, some relative contraindications. But I would say right now, if someone has had a lot of surgery from trauma or something on that line in the area, and now they've got a lesion in their lung, but they've had previous trauma, God forbid, in the past, and it's all scarred up. That's someone that you're not going to be going in with a robot for.